Hello, dear students. Welcome to this lecture. We are still continuing with what we covered last time, and we are still continuing with our course unit. Just to do a little bit of reminder, last time we talked about pneumothorax. We defined what it is. We defined the mechanism of pneumothorax. We talked about the solution to pneumothorax, in other words, the management, where we talked about the chest tube and the principles on how it operates. Now, to continue from where we ended, in today's lecture, we are going to cover cardiac tamponade. Now, cardiac tamponade, as you can see the term there, cardiac stands for the heart. What do we mean by cardiac tamponade? Before we go into the definition, you are supposed to know that the heart has 3 layers. The layers of the heart are basically 3. There's what we call the endocardium. There's what we call the myocardium. And there is what we call the pericardium. Now, the pericardium is the outer layer of the heart. And so you should know that the heart has those 3 layers. Now, if I can illustrate the diagram of the heart in simple terms, assuming this is our heart. Assuming this is our heart. Assuming that is our heart, whereby these are the atria, and then these are the 2 ventricles. Now, the inner layer is what we call the endocardium. Then the muscular layer is what we call the myocardium. Now, the pericardium is divided into 2 layers. Yeah, 2 layers. There's a layer that attaches the heart. There's a layer that attaches on the heart itself. A layer of the pericardium that attaches on the heart itself is what we refer to as the visceral layer. The layer that attaches on the heart itself is what we refer to as the visceral layer. Now, that visceral layer is continuous with another layer which attaches to the other adjacent structures of the heart. In other words, it is continuous with the other layer that attaches to the other adjacent structures of the heart. So in other words, we have something like that. Yeah. So we have this layer here, and then we have the outer layer there. Now, the innermost layer is what we refer to as the visceral pericardium. Visceral pericardium. So in other words, the innermost layer is the visceral pericardium. Visceral pericardium. Now, the outermost is what we refer to as the parietal pericardium. Parietal pericardium. Now, the parietal pericardium and the visceral have a space within them, the space that we call the pericardial cavity or the pericardial sac. Now, in a normal person, this sac is filled with fluid. Yeah, very little fluid, about 50 mils of clear fluid. Yeah, so this sac is filled with clear fluid, about 50 mils. About 50 mils fills that sac just to prevent friction as the heart relaxes and contracts as it performs its functions. Now, with a pathology or with the condition called pericardial effusion, you realize that this condition leads to accumulation of fluid within this pericardial sac. In other words, you have too much fluid, yeah, within the pericardial sac, and that is referred to as pleural effusion, yeah. So you have, with the pericardial sac, you have too much fluid, a condition we refer to as pleural effusion. You have too much fluid here. So if you have too much fluid, that condition is, as I said, is referred to as pleural effusion. Now, how does cardiac tamponade come about? With cardiac tamponade, it is defined as accumulation of fluids within the pericardial sac to the extent that it limits or it inhibits the relaxation and contraction of the heart. In other words, it limits or it inhibits the normal functioning of the heart. Remember, the heart is supposed to contract and relax, and in that case, performing its normal function. However, with cardiac tamponade, the heart is unable to perform its normal function of pumping blood to, to the body or other parts of the body. So cardiac tamponade basically limits the heart to perform its role. Now, how is it diagnosed? How is this condition diagnosed? Now, this condition is diagnosed at the bedside, and even with taking history and with clear signs and symptoms, as we are going to see. Now, later on, they can do investigations like echocardiography or even, or even ECG to confirm. Now, we said what factors basically contribute to cardiac tamponade is that the rapidity with which fluid is accumulating, that is factor number one. Then the amount of fluid that accumulates here is factor number two. And then the compliance of the sac. If this sac is able to stretch out so that it can able to contain fluid, then the patient will not have cardiac tamponade. In other words, the point to take home here is that cardiac tamponade results from fluid filling the pericardial sac to the extent that it limits the normal functioning of the heart. So in other words, all cardiac tamponade results from pericardial effusion, but not all pericardial effusion can result into cardiac tamponade. Now, what are the types of cardiac tamponade? We have what we call acute and subacute or chronic. Now, the acuteness or chronic basically comes, the acute is as a result of, fluid accumulating rapidly in the sac, yeah? In other words, you have too much fluid that is accumulating rapidly in the sac here, and therefore bringing or contributing to these chambers. It makes these chambers really so unable to perform their function. It compresses these chambers so much to the extent that they are unable to perform their function. Yeah. So, and all this is fluid. So it compresses the heart. It compresses these chambers so much that it is unable to perform its function. Now, it is acute when about 100 to 200 mils, rapidly accumulate into this sac here. Yeah. And what can be the cause? So one of the causes can be, you know, trauma to the chest. And if there is trauma to the chest, like for example, if there was injury here, injury to the sac here, injury to the sac here, as a result of trauma, if there was injury to the sac there as a result of trauma, you'd have fluid accumulating there in the sac. So it can also be as a result of what we call posterior, rather post-myocardial infarction free wall rupture. In other words, we are saying that if we have a myocardial infarction, basically an infarction means part of the wall of the heart chamber is destroyed, yeah, because of not being supplied with oxygen and nutrients, yeah. So when it is destroyed, it basically ruptures. Imagine, like for example, if it is this part which has been destroyed and it ruptures, then the blood will gush, yeah. The blood will gush to flow, you know. The blood will gush to flow into the space, yeah. And so the other one is aortic dissection, yeah. The other one is aortic dissection. And by aortic dissection, this is what we mean. This is what we mean by aortic dissection. Assuming this is your heart, assuming this is your heart and this is your aorta, yeah? This is your aorta, this is your left part of the heart, this is your aorta, these are the aortic valves, yeah? Now this aorta, remember, it is an artery, yeah, which is quite big. Assuming that is our aorta. Assuming that is our aorta. Now, remember, as this ventricle, left ventricle contracts, it pumps blood to go out of the, you know, out of the aorta to the rest of the body. So, with aortic dissection, what actually happens is that part of the layer, remember, an artery is made up of 3 layers. We have what we call the intima, the tunica media, and then the adventitia. So what actually happens is that because of the high pressure within the aorta, as this left ventricle pumps, it might cause, as blood gushes, it might cause rupture here, yeah, in the aortic wall. It might cause rupture here in the aortic wall, as you can see, and therefore blood, you know, blood turns or blood flows within the pericardial sac, yeah. So you'll have blood flowing or coming, and it occupies the pericardial sac. Yeah, so that is what we refer to as aortic dissection. Aortic dissection. Because of the too much pressure here, part of the aorta is ruptured. Part of the aorta is ruptured, and then the blood flows into the sac. But it can also be as a result of other things, like, for example, post-cardiac operations. Yeah, post-cardiac operations. It can be subacute or chronic, and if you have observed, we see that with subacute or with chronic, what actually happens is that very little volume is required. So this is how aortic dissection can lead to acute cardiac tamponade. Now, chronic cardiac tamponade, this one occurs as a result of too much fluid that accumulates within the chamber, and it can go up to 2,000 mils. And usually this is caused by either a neoplasm or a cancer, and in most cases there are metastases or even tuberculosis. Now, how does cardiac tamponade present? There's what we call a triad, and that is what we call Beck's triad. Now, triad means three things. We have increasing jugular venous pressure. Remember, we are saying that if the heart is too much, if the heart is too much pressed, if the heart is too much pressed like that, yeah, if the heart is too much pressed like that, and then you have too much fluid, remember, and all this is fluid. So this whole fluid is exerting a pressure. And remember, the atria are supposed to be bringing back blood from up there. Are supposed to be bringing back blood from up. And as a result, because of too much pressure here, blood will not be able to come back to the heart. And as a result, it will engorge, or it will accumulate in the jugular veins. That is why we have jugular venous pressure increasing, yeah? Because blood is unable to return to the heart because of the too much pressure that is pressing onto the heart chambers. The other one is what we call a falling blood pressure. Remember, because little blood is returning to the heart, therefore the blood pressure will also be low because there will be nothing to pump. Remember, blood pressure is equal to cardiac output times total peripheral resistance. So, if we don't have a cardiac output, or if we are pumping out little, then the blood pressure will fall. So, we have what we call falling blood pressure with what we refer to as pulsus paradoxus. Now, pulsus paradoxus refers to a decrease of more than 10 millimeters of mercury in the systolic blood pressure during inspiration. A decrease of more than 10 millimeters of mercury in the systolic blood pressure during inspiration. Now, the other sign or the other component of the triad is what we refer to as muffled or distant heart sound. Remember, when you auscultate, when you put your stethoscope onto your ears and then auscultate the chest, because of too much fluid here, because of too much fluid accumulation within this cavity here, when you put your stethoscope to auscultate on the chest, you'll hear as if the heart sounds are very distant, or even you might not hear them. So that is what we refer to as muffled or distant heart sounds. Other things include anxiety, restlessness, low blood pressure, weakness, chest pain, among others. Now, how do we diagnose cardiac tamponade? We usually do echocardiography, and echocardiography is like the ultrasound. Yeah. So the ultrasound of the heart is what we refer to as echocardiography, and usually we see collapse of the right atria and ventricles, and then also the inferior vena cava is distended, and the heart is swinging. Yeah. In other words, the heart is in too much fluid, so it swings. We can also do ECG. We can also do X-ray, whereby we see an enlarged cardiac shadow. And then we can also do pericardiocentesis, whereby we inject in the chest wall to remove this fluid, yeah? Pericardiocentesis. Now, what interventions do? You need to place the client. The client needs to be placed in a critical care unit or ICU. Then you need to administer fluid intravenously, yeah, to manage the decreased cardiac output. Prepare the client for chest X-ray or even other investigations. Monitor for recurrence of cardiac tamponade following pericardiocentesis. If the client experiences recurrent tamponade or recurrent effusions, then there is need to develop what we call there's need to do what we call a pericardial window. Yeah, there's need to do to do a pericardial window, whereby they make sure they put a hole here, and then the fluid is accessed via the pleural cavity. Now, what are the nursing diagnoses? One of them is decreased cardiac output, and which may be related to altered myocardial contractility. And then the other one might be, pain. And also all those are examples of nursing diagnosis. I want you to find more about nursing diagnosis. Now that has been that about cardiac tamponade. Basically, it is accumulation of fluid within the pericardial sac to the extent that it limits or it interferes with the normal functioning of the heart. Now let's briefly talk about lung cancer, because we are supposed to talk about this. Now, you know what a cancer is. And so lung cancer is a malignant tumor of the bronchi and peripheral lung tissue. And the lungs, are the common sites of metastasis from other organs. So in most cases, this lung cancer is as a result of metastasis. Now, the carcinoma can arise centrally, or it can arise peripherally. This is what we are saying. The carcinoma can come centrally, or it can be peripheral. Peripheral. So this is what we are saying. If these are our lungs, so these are our lungs. We are saying that the carcinoma can arise centrally. In other words, it can come where these bronchi attach the lungs. Yeah, so it can arise from there. Yeah, there. Or it can come as a result of peripheral. It can arise from this side, or it can arise from that side. Yeah, so that is what we are saying. So it can arise centrally, and that is what we call squamous cell or small cell. Or it can be peripheral, and that is what we call adenocarcinoma or large cell carcinoma. Now, what are the risk factors? Are things like smoking, asbestos, radiation, genetics, and HIV infection. What are the clinical manifestations of lung cancer? Things like cough. Hemoptysis is when you cough blood. Chest pain, dyspnea, hoarseness of voice. In other words, you have a hoarse voice. Pleural effusion, anorexia, weight loss, weakness, all these are manifestations of lung cancer. What investigations are done? We do chest X-ray, CT scan, MRI, and then bronchoscopy. Yeah, these ones are done to pick or to know whether a patient is having lung cancer. Now, what investigations do we do for these patients? For this patient with lung cancer? Now, one, we have to monitor vital signs. We have to monitor breathing pattern. You need to assess for tracheal deviation. Administering analgesics is very important. Pulse oximetry, among others, as you can see in that presentation there. So those are some of the things that we do for this patient. And And so you do interventions. They are non-surgical interventions, as you can see. And then we also have what we refer to as the surgical interventions. Things like laser therapy, things like thoracentesis, or what we call, you know, the chest tube that we put, things like thoracotomy, yeah, or even lobectomy, where we remove the lobe that is basically affected, yeah, and then postoperative interventions are those, as you can see in the presentation. So that is basically what we do for a patient who has got lung cancer. Now, these are some of the nursing diagnoses, things like ineffective airway clearance, which can be related to increased amount of viscosity of secretions, restricted chest movement due to pain, fatigue, and even weakness. You will look at that table. That table has the diagnosis, the expected outcomes, the interventions that the nurse can do either independently or collaboratively, and then the reason as to why they are being done. And then ongoing assessment that has to be done. The other diagnosis is impaired gaseous exchange, yeah, which may be related to removal of the lung tissue in case it is removed, or altered oxygen supply, yeah. So all these are some of the examples of diagnoses that are evident in patients who have lung cancer. Then the other one is acute pain. Acute pain is also an example of a diagnosis that is evident in patients who have lung cancer. So in a nutshell, today we've looked at cardiac tamponade, and we have also looked at lung cancer. Now, please, in case you need more information, in case you do not understand some of these concepts, please read the book that was availed to you. And I want to thank you for, you know, being attentive, and please make sure that you get this presentation, and therefore be able to follow. And then please stay home and stay safe. When we meet next time, we shall do something else. Thank you.